Dilated cardiomyopathy. Cardiomyopathies are defined as cardiac diseases of the myocardium with associated cardiac dysfunction. They are cardiac diseases in which heart muscle disease and/or measurable deterioration of cardiac muscle function occurs due to various causes, such as genetic and sporadic mutations of muscle proteins, as well as external factors such as hypertension, ischemia, and inflammation. In cardiomyopathy, the heart muscle becomes enlarged, thick, or rigid. In rare cases, the muscle tissue in the heart is replaced with scar tissue. As cardiomyopathy worsens, the heart becomes weaker. It's less able to pump blood through the body and maintain a normal electrical rhythm. This can lead to heart failure or irregular heartbeats called arrhythmias. In turn, heart failure can cause fluid to build up in the lungs, ankles, feet, legs, or abdomen. The weakening of the heart muscle also can cause other complications such as heart valve problems. Dilated cardiomyopathy is the most common type, occurring mostly in adults 20 to 60. It affects the heart ventricles and atria, the lower and upper chambers of the heart, respectively. Frequently, the disease starts in the left ventricle, the heart's main pumping chamber. The heart muscle begins to dilate, meaning it stretches and becomes thinner. Consequently, the inside of the chamber enlarges. The problem often spreads to the right ventricle, then to the atria. As the heart chambers dilate, the heart muscle doesn't contract normally and cannot pump blood very well. As the heart becomes weaker, the heart failure can occur. Common symptoms of heart failure include shortness of breath, fatigue, and swelling of the ankles, feet, legs, abdomen, and veins of the neck. Dilated cardiomyopathy also can lead to heart valve problems, irregular heartbeats, and blood clots in the heart. Other names known as alcoholic cardiomyopathy, congestive cardiomyopathy, diabetic cardiomyopathy, familial dilated cardiomyopathy, idiopathic cardiomyopathy, ischemic cardiomyopathy, and peripartum cardiomyopathy. About one-third of the people who have dilated cardiomyopathy inherit it from their parents. Dilated cardiomyopathy is more common in African Americans than whites, and this type of the disease also is more common in men than women. It is known that coronary artery disease, inflammatory heart disease, myocardial toxins, and genetic defects can cause DCM in adult patients. In children DCM patients, the cardiac disease characteristics are much more diverse than those in adults, and incidence largely depends on age, race, and gender. Approximately 30 to 35% of young patients are reported to have a genetic form of DCM. Myocardial ischemia remains a common cause of DCM, accounting for approximately half of DCM. Toxic, metabolic, and immunologic causes have each been linked to DCM, as well as hypertension and valvular disease. Genetic cardiomyopathy, which runs in families, is now more commonly diagnosed, largely because surveillance for and awareness of the condition have improved. It is also now increasingly understood that more than one etiology may contribute to DCM within a given individual. Unlike cardiomyopathy that results from some of the other causes, genetic cardiomyopathy is a progressive disease. More than 20 viruses can cause DCM. In Central and South America, Chagas disease is the most common infectious disease, although it is a cause of only 10% of heart failure cases in recent series. DCM is becoming increasingly common among patients with active HIV infection. Other causes include prolonged tachycardia, toxoplasmosis, thyrotoxicosis, and beriberi. Many toxic substances, particularly alcohol, various organic solvents, iron or heavy metal ions, and certain chemotherapeutic drugs damage the heart. Frequent ventricular ectopy has been associated with left ventricular systolic dysfunction. Sudden emotional stress and other hyperadrenergic states can trigger acute dilated cardiomyopathy that is typically reversible. An example is acute apical ballooning cardiomyopathy. In this disorder, usually the apex and occasionally other segments of the LV is affected, causing regional wall dysfunction and sometimes focal dilation. Recent findings indicate that the genetic and sporadic mutations of many muscle proteins, such as sarcomere proteins, structural proteins, nuclear envelope proteins, and calcium regulating proteins, Sarcomere proteins include heavy and light chain myosin and myosin binding proteins, cardiac actin, alpha-tropomyosin, troponin complexes, and others. Mutations in relevant genes can cause both HCM and DCM. It is estimated that myofibrillar protein mutation accounts for roughly 10% of familial DCM cases, but a recent finding suggests that 25% of idiopathic DCM causes are due to sarcomere gene mutations. Since the generation of contractile forces by sarcomeric proteins and force transmission to the extracellular matrix are fundamental heart cell functions. Inadequate performance or either function may result in ventricular cavity dilation that leads to subsequent heart failure. In addition to gene mutations that affect sarcomere proteins, genetic mutations of structural proteins such as intermediate filament proteins and the dystrophin-associated glycoprotein complex are known as a cause of DCM. Intermediate myofilaments are important components of the cytoskeletal system that stabilize organelles by linking the Z-disc to the sarcolemma. Nuclear lamins are intermediate filament proteins that polymerize to form the nuclear lamina on the inner aspect of the inner nuclear membrane. It is believed that lamins are essential for maintaining nuclear structure and for disassembly and reassembly during mitosis. While lamins are expressed in all mammalian somatic cells, mutation in their genes lead to relatively tissue-selective disease phenotypes such as DCM. Calcium-regulating proteins and disturbed ion channel function have been identified as causative of DCM. Phospholambin is known as a regulator of calcium uptake into the sarcoplasmic reticulum via the inhibition of CA2 and cardiomyocytes. In DCM, several complex pathophysiological processes promote intrinsic myocardial impairment and remodeling, including diffuse extracellular matrix remodeling, myofibroblast transformation, and cardiomyocyte loss, affecting the myocardium globally. Regardless of the cause, the myocardium dilates, thins, and hypertrophies in compensation, often leading to functional mitral regurgitation or tricuspid regurgitation and atrial dilation. As DCM progresses, two compensatory mechanisms are activated in response to impaired myocyte contractility and reduced stroke volume, such as the Frank-Starling law and neurohormonal feedback. As a primary myocardial disorder, the myocardial dysfunction occurs in the absence of severe occlusive coronary artery disease or conditions that involve pressure or volume overload of the ventricle. In some patients, dilated cardiomyopathy is believed to start with acute myocarditis, followed by a variable latent phase, a phase with diffuse necrosis or myocardiomyocytes, and chronic fibrosis. Regardless of the cause, the myocardium dilates, thins, and hypertrophies in compensation, often leading to functional mitral regurgitation and tricuspid regurgitation. This disorder affects both ventricles in most patients, only the left ventricle in a few, and only right ventricle rarely. As said before, the two compensatory mechanisms are the Frank-Starling law and neurohormonal feedback. This is via the activation of the sympathetic nervous system and the renin-angiotensin system. These responses initially compensate for decreased cardiac output and maintain those with DCM as asymptomatic. Eventually, however, these mechanisms become detrimental, intravascular volume becomes too great, and progressive dilation leads to heart failure symptoms. As the ventricles enlarge, both the mitral and tricuspid valves may lose their ability to come together properly. This loss may lead to mitral and tricuspid regurgitation. As a result, those with DCM are at an increased risk of atrial fibrillation. Furthermore, stroke volume is decreased, and a greater volume load is placed on the ventricle, thus increasing heart failure symptoms. Glycogen synthase kinase 3 is a highly conserved integral regulator of numerous cellular processes, including cell proliferation, metabolism, and cell death. Mice with adult cardiac myocyte-specific deletion of both isoforms of GSK3, double knockout DKO, rapidly succumb to death. Microarray analysis of DKO hearts identified GSK3 regulated transcriptional changes that provide insight in adult cardiac myocyte cell cycle activation. DKO adult cardiac myocytes exhibited cell cycle reentry resulting in increased DNA content and multinucleation. However, instead of successful completion of cell cycle, cardiac myocytes accumulated severe DNA damage, activated cell cycle checkpoints, and culminated in mitotic catastrophe. The loss of cardiac myocytes severely impaired cardiac function and ultimately caused DCM and heart failure. Thus, cardiac myocyte GSK3 is required to maintain cardiac homeostasis and overall survival. This is a schematic representation of the effects of glycogen synthase kinase 3 deletion on cardiac myocyte cell cycle. During normal cardiac development, cardiac myocytes retain the ability to proliferate. These cells are mononucleated during early development to birth, but progress to a predominantly post-mitotic binucleated state by maturity. On deletion of GSK3, adult cardiac myocytes re-enter cell cycle. Cell cycle reentry is opposed by cell cycle checkpoint activation and DNA damage. Although it is clear that double knockout cardiac myocytes are able to bypass critical checkpoints to complete karyokinesis, these cells have impaired mitotic capacity and do not progress to cytokinesis. Instead, abnormal mitosis within these cells induces mitotic catastrophe, resulting in a loss of functional cardiac myocytes. A possible alternative hypothesis showing loss of cardiac myocyte GSK3 may lead to apoptotic cell death without cell cycle reentry, which has been shown by dotted line. Mice develop dilated cardiomyopathy as a result of cardiac myocyte loss and ultimately succumb to death. GSK3 in the adult cardiac myocyte is a critical suppressor of cell cycle induction, and its loss leads to improper cell cycle reentry, culminating in mitotic catastrophe. This associated loss of functional cardiac myocytes then results in impaired cardiac function with rapid onset of congestive heart failure and death in the DKO mice. Many people with dilated cardiomyopathy have no symptoms or only minor symptoms and live a normal life. Other people develop symptoms which may progress and worsen as heart function worsens. Those who do show signs and symptoms will include heart failure symptoms like shortness of breath and fatigue, swelling of the lower extremities, fatigue, weight gain, fainting, palpitations, dizziness or lightheadedness, blood clots, chest pain or pressure, and sudden death. A person suffering from dilated cardiomyopathy may have an enlarged heart with pulmonary edema and an elevated jugular venous pressure and a low pulse pressure. They will also show signs of mitral and tricuspid regurgitation may be present. This is a table of characteristics of patients with dilated cardiomyopathy that include family history, diabetes, hypertension, chemotherapy, stimulant use, high alcohol intake, and arrhythmias. The diagnosis of dilated cardiomyopathy is by history, physical examination, and exclusion of other common causes of ventricular failure, such as systemic hypertension, primary valvular disorders, myocardial infarction. Thus, chest X-ray, EKG, echocardiography, and more recently, cardiac MRI are required. Serum cardiac markers are measured if acute symptoms or chest pain is present. Although typically indicative of coronary ischemia, troponin elevation often occurs in heart failure, especially renal function is decreased. Serum natriuretic peptide levels are typically elevated when heart failure is present. Chest X-ray will show cardiomegaly, usually of all chambers. Pleural effusion, particularly on the right, often accompanies increased pulmonary venous pressure and interstitial edema. The ECG may show sinus tachycardia and non-specific ST segment depression with low voltage or inverted T waves. Cardiac MRI is increasingly done and is useful in providing detailed imagery of myocardial structure and function. MRI with gadolinium contrast may show abnormal myocardial tissue texture or scarring pattern. Treatment of dilated cardiomyopathy is aimed at decreasing the heart size and the substances in the bloodstream that enlarge the heart and ultimately lead to worsened symptoms. Treatment is the same as for heart failure with reduced ejection fraction, being ACE inhibitors, beta blockers, aldosterone receptor blockers, angiotensin II receptor blockers, valsartan, sacubitril, hydrolyzine, nitrates, diuretics, and digoxin. If you have heart failure, sodium should be restricted to 2,000 to 3,000 milligrams per day for the rest of your life. Abnormal electrolyte levels may be a sign of dehydration, heart failure, high blood pressure, or other disorders. Aldosterone blockers are an example of a medicine used to balance these electrolytes. Antiarrhythmics help prevent arrhythmias. ACE inhibitors, angiotensin II receptor blockers, beta blockers, and calcium channel blockers are examples of medicines that lower blood pressure. Anticoagulants or blood thinners are an example of medicines that provide blood clots. Blood thinners are often used to prevent blood clots from forming in people who have dilated cardiomyopathy. Corticosteroids are an example of medicine used to reduce inflammation, and diuretics or water pills are an example of medicines that help remove excess sodium from the body, which reduces the amount of fluid in your blood. Beta blockers, calcium channel blockers, and digoxin are examples of medicines that slow the heart rate. Beta blockers and calcium channel blockers are used to lower blood pressure. DCM is a disease of the myocardium and is the most common reason for cardiac transplantation in adults and children. Therefore, people with severe DCM may need one of the following surgeries: a cardiac resynchronization by a biventricular pacemaker. For some people with DCM, stimulating both the right and left ventricles with this pacemaker improves the heart's ability to contract with more force, thereby improving symptoms and increasing the length of time you can exercise. This pacemaker also will help people with heart block and some bradycardias. Implantable cardioverter defibrillators, or ICDs, are suggested for people at risk for life-threatening arrhythmias or sudden cardiac death. The ICD constantly monitors the heart rhythm. When it detects a very fast abnormal heart rhythm, it shocks the heart muscle into returning to a normal rhythm. Surgery. Conventional surgeries for coronary artery disease or valvular disease may be recommended. Some people may be eligible for surgical repair of the left ventricle or placement of a cardiac assist device, and also heart transplants. A 54-year-old male self-presented to the emergency department with a 4-day history of awareness of irregularities of his heart rhythm. This was not accompanied by any chest pain, but he revealed a 1-month history of shortness of breath, tiredness, and leg swelling. He also reported general malaise and decreased libido. He had recently stopped smoking when the symptoms first started and used to smoke 15 cigarettes a day prior to that for 25 years. He had no prior medical or surgical history other than mild asthma for which he had not been hospitalized previously. On admission, he found to have a narrow complex tachycardia, which reverted to normal sinus rhythm with intravenous verapamil. Initial investigation showed troponin 1 of 0.22, a BMP of 899, and raised D-dimers of 664. A CT pulmonary angiogram excluded a pulmonary embolus. A transthoracic echocardiogram showed mildly dilated left and right ventricles with global hypokinesia and severe biventricular systolic dysfunction. The left ventricular ejection fraction was calculated by Simpson's method to be 15%. The echocardiogram also showed that there was no left ventricular hypertrophy or valve disease of any significance. A full cardiomyopathy biomarker screen was negative for any secondary causes. Coronary angiography revealed only mild atheroma in the proximal left anterior descending and mid-right coronary arteries. The patient had no further rhythm disturbances on CCU and lost 6.2 kilograms in weight during his 5-day stay as an inpatient. Treatment in the acute setting is aimed at reducing in preload and afterload and improving cardiac contractility. Diuretics, including furosemide and spirolactone, angiotensin-converting enzyme inhibitors, and digoxin are currently the mainstay of long-term management. The use of isosorbide in combination with hydrazaline have been used in patients intolerant of ACE inhibitors, and there is some evidence that their addition on top standard treatments in patients with severe symptoms of cardiac failure may improve mortality. Amiodarone can be used in those who are prone to arrhythmias, but consideration should be given to an implanted defibrillator. Beta blockers should always be considered as they may counteract the effect of sympathetic activation of the remodeling of the heart. However, they should only be initiated once the patient is stable due to their negative inotropic effects. Diabetic myopathy. Diabetic cardiomyopathy is initially characterized by myocardial fibrosis, dysfunctional remodeling, and associated diastolic dysfunction, later by systolic dysfunction, and eventually by clinical heart failure. The prevalence of diabetic cardiomyopathy is increasing in parallel with the increase in diabetes mellitus. Impaired cardiac insulin metabolic signaling, mitochondrial dysfunction, increase in oxidative stress, reduced nitric oxide bioavailability, elevations in advanced glycation end products, and collagen-based cardiomyocyte and extracellular matrix stiffness, impaired myocardial and cardiomyocyte calcium handling, inflammation, renin-angiotensin-aldosterone system activation, cardiac autonomic neuropathy, endoplasmic reticulum stress, microvascular dysfunction, and a myriad of cardiac metabolic abnormalities have all been implicated in the development and progression of diabetic cardiomyopathy. Molecular mechanisms linked to the underlying pathophysiological changes include abnormalities in AMP-activated protein kinase, peroxisome proliferator activated receptors, O-linked and acetylglucosamine, protein kinase C, microRNA, and exosome pathways. Diastolic dysfunction, characterized by impaired diastolic relaxation time and reduced contractility, precedes systolic dysfunction and is the main pathogenic hallmark of this condition. Even though the pathogenesis of diabetic cardiomyopathy is still controversial, impaired cardiac insulin sensitivity and metabolic overload are emerging as major molecular and metabolic mechanisms for cardiac dysfunction. Systemic insulin resistance, hyperinsulinemia, dysregulation of adipokine secretion, increases in circulating levels of inflammatory mediators, aberrant activation of renin-angiotensin-aldosterone system, and increased oxidative stress contribute dysregulated insulin and metabolic signaling in the heart and development of diastolic dysfunction. In addition, maladaptive calcium homeostasis and endothelial cell dysregulation, endoplasmic reticular stress play a potential role in cardiomyocyte fibrosis and diastolic dysfunction. You can see from the graph that insulin resistance, hyperinsulinemia, hyperglycemia, oxidative stress, inflammation, and dyslipidemia can all lead to cardiac diastolic dysfunction, leading to heart failure. This can all be done by overactivation of the renin-angiotensin-aldosterone system, dysregulated cardiac and metabolic signaling, and cardiac mitochondrial and endoplasmic reticulum dysfunction, thereby leading to cardiac fibrosis and remodeling, cardiomyocyte apoptosis, exacerbation of initial oxidative stress, reduced cardiac efficiency, and impaired cardiac calcium homeostasis, thereby leading further to reduced ATP and increased cell death, impaired cardiac contractility, and prolonged diastolic relaxation time, thereby leading to cardiac diastolic dysfunction, in turn leading to heart failure. Potential contributors to the development of diabetic cardiomyopathy. Increased free fatty acids activates PPAR alpha signaling, leading to the increased transcription of many genes involved in fatty acid oxidation. Increased fatty acid oxidation leads to the generation of reactive oxygen species at the level of the electron transport chain. ROS, which also can be generated by extra mitochondrial mechanisms such as NADPH oxidase, plays a critical role in several pathways involved in the pathogenesis of diabetic cardiomyopathy, including lipotoxicity, cell death, and tissue damage, as well as mitochondrial uncoupling and reduced cardiac efficiency. In a diabetic heart, there is a significant disruption of molecular processes essential for normal cardiac function. First, calcium signaling is impaired, leading to altered relaxation-contraction dynamics and the resultant diastolic and systolic dysfunction. Second, the heart shows signs of increased oxidative stress, which damages structural components of the heart and activates signaling pathways such as NF-κB, CGN, N-terminal kinases, and mitogen-activated protein kinases through oxidative stress modifications to selective residues. Third, endoplasmic reticulum stress and accumulation of unfolded proteins exert significant toxicity and eventually lead to cardiomyocyte apoptosis. Finally, disruption in cytokine signaling and low-grade inflammation of the heart further repress cardiac function in diabetes. In addition to these pathways, diabetic cardiomyopathy is being exceedingly recognized as a metabolic disease of the heart, characterized by increased reliance on fatty acids, compared with glucose as a source of energy, and the resulting maladaptive changes of this metabolic switch. The early stage in DCM involves oxidative stress and endoplasmic reticulum stress, concomitant with O-linked glycosylation of receptors and extracellular matrix proteins, and formation of advanced glycation end products, or AGE. This further influences myocyte apoptosis and steatosis, which is followed by fibrosis and remodeling, thus altering the physiological functioning of the heart. In diabetes, mitochondria are a predominant source of intracellular reactive oxygen species, and are themselves a primary target of oxidative injury. Damaged mitochondria can further increase ROS production through ROS-induced ROS release and may trigger leakage of pro-death factors, settling in motion a vicious cycle to induce cardiomyocyte death. Indeed, increased mitochondrial production of ROS and damaged mitochondrial structure and function are commonly seen in the hearts of both type 1 and type 2 diabetic patients and animal models. The causative role of ROS in the pathogenesis of diabetic cardiomyopathy is well established in animal studies by the ability of various antioxidants to reduce diabetic heart injury. However, the efficacy of antioxidant therapy has not been reproduced in diabetic patients thus far. The inconsistency between animal studies and clinical trials could result from the heterogeneity of the patient populations and/or the types of antioxidants used. Further research in more homogeneous patients using more robust antioxidants may help resolve this issue. On the other hand, it is possible that antioxidants cannot block continuous formation of ROS, despite their ability to scavenge existing ROS. If this is true, a more effective therapeutic strategy for diabetic cardiomyopathy may be to timely eliminate aged and dysfunctional mitochondria, which would otherwise constantly generate ROS and release pro-death factors. Presumably, this could be achieved by autophagic sequestration and lysosomal degradation of injured mitochondria, a process termed mitophagy, that plays an important role in mitochondrial quality control and cellular homeostasis. Diabetic cardiomyopathy has been classified into stages based on ejection fraction and phenotypic changes in left ventricles. The initial stage of DCM is asymptomatic, marked by left ventricular hypertrophy with normal ejection fraction, followed by stage 2 with noticeable dilation and reduced ejection fraction. Patients with systolic and diastolic dysfunction mediated by contributing factors such as hypertension and myocarditis are considered in stage 3. And the final stage, designated as end stage or refractory heart failure with ischemia, infarction, and remodeling. This stepwise progression of DCM has been engendered due to hyperglycemia-mediated metabolic dysregulation, ensuing cardiac apoptosis, necrosis, fibrosis, steatosis, hypertrophy, and remodeling. Such structural modifications influence cardiac dysfunction characterized by an initial diastolic dysfunction followed by an altered systolic function. The pathophysiological factors in diabetes that drive the development of cardiomyopathy include a systemic metabolic disorders, inappropriate activation of the renin-angiotensin-aldosterone system, subcellular component abnormalities, oxidative stress, inflammation, and dysfunctional immune modulation. These abnormalities collectively promote cardiac tissue interstitial fibrosis, cardiac stiffness, diastolic dysfunction, and later systolic dysfunction, precipitating the syndrome of cardiac heart failure. Recent evidence has revealed that dysregulation of coronary endothelial cells and exosomes also contribute to the pathology behind diabetic cardiomyopathy. The main metabolic abnormalities in diabetes are hypoglycemia, hyperlipidemia, and inflammation, all of which stimulate generation of reactive oxygen or nitrogen species that cause most of the diabetic complications, including diabetic nephropathy and cardiomyopathy. Previous studies in skeletal muscle reported alterations in the excitation-contraction coupling, a coordinated chain of cellular events that links the membrane action potential with intracellular calcium release and activation of the contractile machinery. Muscle fibers cultured in elevated glucose for 48 hours exhibit predominantly biphasic action potential-induced calcium transients in response to single-field stimulation. Thus, glucose-induced alterations in calcium transients could play a role in the progression of muscle weakness and observed in diabetic myopathy. Increased reactive oxygen species production in the diabetic heart is a contributing factor in the development and the progression of diabetic cardiomyopathy. Superoxide-mediated damage or cellular dysfunction results when an imbalance exists in ROS generation and ROS degrading pathways. Increased ROS generation and impaired antioxidant defenses could both contribute to oxidative stress in diabetic hearts. Several groups have shown that ROS is overproduced in both type 1 and type 2 diabetes. Diabetic cardiomyopathy may not cause symptoms in its early stages. Later, you may have weakness, shortness of breath, a severe cough, fatigue, and swelling of the legs and feet. One particularity of diabetic cardiomyopathy is the long latent phase, during which the disease processes but is completely asymptomatic. In most cases, diabetic cardiomyopathy is detected with concomitant hypertension or coronary artery disease. One of the earliest signs is mild left ventricular diastolic dysfunction with little effect on ventricular filling. Also, the diabetic patient may show subtle signs of diabetic cardiomyopathy related to decreased left ventricular compliance or left ventricular hypertrophy or a both combination of both. A prominent A wave can also be noted in the jugular venous pulse, and the cardiac apical impulse may be overactive or sustained throughout systole. After the development of systolic dysfunction, left ventricular dilation, and symptomatic heart failure, the jugular venous pressure may become elevated. The apical impulse would be displaced downward and to the left. Systolic mitral murmur is not uncommon in these cases. These changes are accompanied by a variety of electrocardiographic changes that may be associated with diabetic cardiomyopathy in 60% of patients without structural heart disease, although usually not in the early asymptomatic phase. Later in the progression, a prolonged QT interval may be indicative of fibrosis. Given that diabetic cardiomyopathy's definition excludes concomitant atherosclerosis or hypertension, there are no changes in perfusion or in atrial natriuretic peptide levels up until the very late stages of the disease, when the hypertrophy and fibrosis become very pronounced. In the early stages, there are only substructural changes in the cardiomyocytes, and the detection is possible only by very sensitive methods such as strain rate, and myocardial tissue velocity. Later on, myocyte hypertrophy and fibrosis develop that may be associated with structural changes like left ventricular hypertrophy and increased muscle mass. Conventional diagnostic methods such as echocardiography may detect diastolic and systolic dysfunction at this stage. Significant microvascular changes and fibrosis occurs in the myocardium in advanced stages, and this stage is usually associated with hypertension, overt heart failure, and ischemic heart disease. Echocardiography is a relatively inexpensive diagnostic tool for detecting structural and functional cardiac abnormalities. Transmitral Doppler is the usual technique for assessment of the ventricular diastolic function. The variables measured by the transmitral Doppler are the early ventricular filling wave and the late ventricular filling wave, which can be reported as an EA ratio, the isovolumetric relaxation time, E-wave peak velocity, E-wave deceleration time, and A-wave duration. Tissue Doppler imagery measures myocardial tissue velocities during the cardiac cycle and can be used to quantitatively assess global and regional systolic and diastolic functions of the myocardium. Cardiac magnetic resonance imagery has recently emerged as a very good imaging tool for the diagnosis of various structural and functional disorders of the myocardium. Changes in the level of various plasma serum cardiac biomarkers may reflect some of the myocardial metabolic, and structural functions. Changes in the plasma level of cardiac biomarkers may reflect several myocardial metabolic changes. Although microribonucleic acids are small, non-coding RNA molecules, they play a key role in modulating gene expression, and their altered level was found in the myocardiocytes in experimental diabetes models. The expressions of several miRNAs are altered by matrix metalloproteinases, which also play an important role in degrading extracellular matrix. The increased turnover of extracellular matrix proteins and alterations of MMP levels are strongly correlated with active cardiac remodeling. Furthermore, elevated levels of MMP9 and reduced levels of TIMPs are associated with myocardial fibrosis. Exosomes emerge as potential biomarkers. Recently, it has been suggested that there is a strong relationship between nutrient sensing and exosome release. Under glucose deprivation conditions, there was an increased exosome production with cardiomyocytes, with these nanovesicles containing glucose transporters and enzymes involved in glycolysis, consequently leading to an increase in glucose uptake and the use of resulting pyruvate production in endothelial cells. Thus, cardiomyocytes-derived exosomes can regulate glucose transport in endothelial cells, the vesicle mechanisms involving GTPases, and several RAS-related protein in the brain. This complex process compromises a convergence of pathways integrating autophagy, vesicle transport, and autosomal synthesis and secretion. There is intense experimental research on potential therapeutic approaches of DCM in considering the essential roles of intracellular calcium imbalance in contractile dysfunction. Mimetic peptides targeting L-type calcium channels have been tested. Strict glycemic control improved stress-induced ventricular dysfunction without CAD in poorly controlled diabetic patients in a large prospective study. Another case-control study using cardiac MRI in patients with T1DM demonstrated the rigorous glycemic control was associated with better DCM outcome parameters. Diabetic management was also beneficial for reducing myocardial-steatosis. Various vasoactive medications have been tried in both human patients and animal models with DCM with variable results. The most studied medications were those where subjects were active on the renin-angiotensin system. The production of AGT2 within the myocardium was proposed as a mechanism for the development of DCM. Recently, angiotensin-converting enzyme inhibitor, renin inhibitor, and angiotensin II receptor blocker were all shown to be protective against DCM in rat models. ARBs and ACEs were also beneficial in both human and animal models of DCM. Dyslipidemias are more detrimental in diabetic than non-diabetic individuals because of their higher atherogenic potential. The particle size of low-density lipoprotein cholesterol is smaller in diabetic subjects, which is more atherogenic even with near normal plasma levels. The use of statins reduces cardiovascular mortality and events in patients with diabetes and vascular risk factors, and is beneficial even when primary prevention in patients without established cardiovascular disease. The vascular remodeling capacity of statins is referred to as a pleiotropic effect. ANG 1 through 7 treatment improves cardiac hypertrophy and diastolic dysfunction in diabetic cardiomyopathy. ANG 1 through 7 treatment represents a potential new therapeutic tool for the treatment of diabetic cardiomyopathy and heart failure with pronounced ejection fraction, in which there is currently limited therapy. In the heart, local activation of angiotensin II type 1 receptor pathway induced mitochondrial damage and impaired titin spring via ROS. Production and loss of leptin signaling compromises this cardioprotective effect against the heart failure. In adipocytes, either local activation of Ang2 or lack of leptin signaling induce obese, leading to influx of macrophage into adipose tissue and secretion of pro-inflammatory mediators, eventually resulting in insulin resistance, altered metabolism, and heart failure with preserved ejection fraction. Ang 1 through 7 binding to mast receptor in cardiomyocytes and adipocytes inhibits Ang2 AT1R pathway and is protective against heart failure with pronounced ejection fraction. Ang 1 through 7 treatment improves cardiac hypertrophy and diastolic dysfunction in diabetic cardiomyopathy. Ang 1 through 7 treatment represents a potential new therapeutic tool for the treatment of diabetic cardiomyopathy in which there is currently limited therapy.